My name is Nikki Stockel, and I'm a Mercer University BSN student for 2016. We're here to discuss today the importance of evidence-based practice and evidence-based protocol. And we have been assigned, as a student, to choose something that was of our interest to try to see if there was a good evidence-based practice or protocol that was in place for this particular subject. I chose mechanical CPR versus manual CPR. It has to do a lot with my background as a nurse in emergency and intensive care, flight nursing, death investigation, and forensics. A few abbreviations, just so some of these folks may not understand what some of these abbreviations are. The basic ones I'm going to skip over, as you can see, they're there. The ones I do want you to know about is OHCA, out of hospital cardiac arrest. Also ROSC, because those are key words, return of spontaneous circulation. Also ILCO. The ILCO is the International Liaison Committee on Resuscitation 2010 levels of evidence for studies of therapeutic interventions. These are key players who help identify what is best interventions for these patients who are in these situations. You guys know what random control trials are, systematic reviews, also mechanical compression devices. I used MCCD, mechanical compression, and then I added the C for chest devices. Another one that a lot of folks may not understand or have interest in because they haven't studied it is ROC Epistry Cardiac Arrest. That is the acronym for Resuscitation Outcomes Consortium Cardiac Arrest Epistry. These guys actually keep up with who actually has a cardiac arrest, what goes on once the paramedics are there, and what are the survival rates and those kind of things. Introduction. Why did I choose this topic? One of the reasons is everyone knows that CPR is something that goes on every day in someone's life somewhere. And also, too, being that said, the American Heart Association has utilized technology in nursing. A long suit followed other companies such as FISO controls, zone defibrillators, mechanical compression devices, Siemens, all these other folks who are jumping on board to actually introduce pacemaker devices, all kinds of things that are coming into play, and nursing are going to have to be integrated with that. Some statistics, over 350,000 out-of-hospital sudden cardiac arrests occur annually. 70% of those are at home. 4 out of 5 of the cardiac arrest happens at home. The American Heart Association trains 17.8 million people in CPR annually to provide for the mentioned population. Of course, that came from statistics from American Heart Association. So as you can see, this is a topic that is very important in everyone's walk of life, internationally, state, local, federally, all of it. Why, again, this topic? I wanted to see and wanted to evaluate what is being said out there, what has been done out there, what kind of practices and protocols are being done, this evidence proof, to evaluate mechanical chest compressions in comparison to manual chest compressions during CPR in and out of hospital cardiac arrest. Our majority of hospitals receive most of their cardiac arrest from out of hospital. Does either method improve the patient survival rate or outcomes? That's what we're here to decide. Which method delivers high-quality CPR per American Heart Association guidelines? Have we been following these pre-hospital cardiac arrest events throughout the hospital stay to discharge? Who knows what's going on with these patients? Who knows what the statistics are? Quality improvements, such as CMS, Center for Medicare Services, and Joint Commission are real huge about making sure that we follow quality gold standards with AMIs, STEMIs, non-STEMIs, other core measures, but this is pertaining to my PICOT question and my discussion. And we don't get paid, the patient doesn't have good outcomes. That is the reason that we have to collaborate with other disciplines. If we don't collaborate with our EMS, where these codes start a lot at, then we don't know what goes on into the field. So collaboration is a must. Compression devices. Why compression devices? Let's give a case scenario. Say you're that nurse who's in a small rural hospital, an emergency room department. You may have a tech there. You may have another nurse, an emergency room physician. You get a patient that's in full-blown cardiac arrest. It's going to take everybody you have there to do that code, and then who is going to take over? Who's going to relieve you? Maybe the house coordinator, whoever can become from the lab person, somebody. In these small rural area hospitals, this can be a problem. Also in large hospitals, because that leaves the other patients unattended. It also reduces provider fatigue if we have a compression device that can do this, CPR. It also been shown to improve hemodynamics, and we'll discuss that shortly. It improves, according to American Heart Association guidelines, our 30 compressions to 2 breaths ratio and death quality. Think about that. Releases staff and care, again, to take care of other patients in the ED. Frees up EMS staff to employ other ACO protocols. They're doing the chest compressions. Then who's going to put in the intraosseous? Who's hanging fluids? Who's giving ACLS drugs? Who's doing the recording? Who's intubating? Who is, suctioning the emesis that may be coming out of the patient? Which lots of times in cardiac arrest that does happen. So this works well also in a moving ambulance. The huge thing I want to point out here, a lot of folks don't realize, is you can defibrillate with these devices going. Well, you cannot with manual CPR. What are the cons? Can't use it on traumatic patients, because think about it. What if they got a liver or spleen lac? They're going to bleed out. What if they are in a head-on collision and their aorta's ripping and they're coming in bleeding anyway, and you don't really know they're bleeding because the patient's coming right from the field, and then you go and put a compression device. They're gone anyway if they have an aorta tear, but what I'm trying to say, if it's a traumatic patient, you don't want to put injury to something that you can save. It's not recommended for pregnant patients. There's a situation that can happen if you're using compression devices with pregnant patients, especially extreme gravid patients. And that is called inferior vena cava compression syndrome. Compression devices pumps, it compresses on the uterine, and then causes the syndrome to happen, and the patient ends up going into, loses the blood pressure, bleeds, also can go into further problems, and also can hurt the baby. You don't want to use them for people under 18 years of age or over 300 pounds. That's a given of why. That's because of the quality of CPR. Possible CPR delay with connecting the device. What if it's, say Nikki just got trained with this device and we're having to unhook it and move the patient, and I'm trying to hook it back up and I don't really know how to use it. Or maybe that new paramedic had an adrenaline rush and forgot how to use it. So there also could be that delay. Must be trained folks to use various companies, your Zoes, your Faisal controls, your Lucas, which is a low band control, your Auto Pulses, which is your band. As you can see there, that is a band one. Manual CPR, what are the pros? It can be used with any patient. Traumatic, cerebral bleeds, pregnancy is not a factor. Again, there's inferior vena cava compression syndrome, which can occur with a mechanical CPR. Also, manual CPR reduces delays as replacing mechanical device. If you don't know how to work the mechanical device, you could cause delay in getting that patient the CPR started fast. Also, CPR is universal. You can go to any country and pretty much people know what CPR is. Can be utilized with all age groups and classes. What are the cons? The staff get wore out. They may have physical disabilities, shoulder problems, wrist problems. They're focusing on several tasks. They may have a screaming family member. They may be having to calculate drugs. They may be having to hang drugs. They may be having to worry about getting a catheter or NG tube or getting the patient intubated. Interruptions during patient movement. Think about it. How many times have you been in a code and you actually move the patient and then you have to stop and you have to time in 2 minutes, and then that can cause delays. Difficulty providing on the CPR on a stretcher. If you're heading to a CAT scanner and you're trying to ride that patient and do CPR, you know it's probably not as good as if you had a compression device. Lack of staff, especially in small EDs, cannot defibrillate when performing manual CPR. Ongoing CPR loses effectiveness is 30-2 ratio. Again, there's my sightings. Literature search. What did I look at? I went through PubMed databases, searched similar articles 5 years. Got up 212. One caught my eye, and I said, that's just too much. I'm going to refine my search. So I went down to most recent in databases 5 years. Got me another one. Cochrane filters. Most recent in database 5 years. Search terms, mechanical chest compressions, and cardiac arrest. 11 articles. Got one there. Biomed. Biomed is a company that is a scientific research who actually goes into PubMed, and they do go into Cochrane, and they go into the same places that we would be going, and they actually pull abstracts from there, and they actually performed appraisals as well. This is the company I chose, and I'll tell you why. They incorporated American Heart in a lot of their literature, which is huge. So, went to American Heart Association, pulled 100 articles, refined my search, put in mechanical CPR and cardiac arrest, 70 articles, one pulled. PICOT question. In adults who are in cardiac arrest and receiving CPR, how effective is mechanical compressions versus manual chest compressions with improving survival rates? Return to spontaneous circulation are examples that improve CPR quality en route to the emergency department. Because again, we're talking about out-of-hospital cardiac arrest. Appraisal chosen. I actually chose the Scandinavian Journal of Trauma and Emergency Medicine, which was under Biomed, and again, that's because they incorporated hospitals globally, also American Heart Association guidelines. So, what best to have all that together. What was my synopsis, my background? The article compared the use and quality of medical compression devices versus manual compression, including the survival rates and ROSC during out-of-hospital cardiac arrest, presenting to the ED in accordance to AHA guidelines. Yay, that's what I was looking for. Population. That inclusion criteria were of adults who were under the age of 16 or at 16 and receiving CPR solely during ambulance transport from an out-of-hospital cardiac arrest to the emergency department. Exclusion criteria were case studies and review articles. What were their methods? Again, we discussed they did the same as what we normally do, and our instructors have taught us to do, is go to trusted areas such as PubMed or databases, Cochrane, American Heart Association. And what did they do? They included random controlled trials, meta-analysis, peer-reviewed by authors in accordance to the ILCR, which we talked about the agency earlier. Evidence evaluation process. The sample size. Out of all the articles, they had 88 identified. 10 studies met the inclusion criteria for review. The level of evidence. What did they find? More research is needed to the articles. As the articles reviewed, it was not clear what type of CPR was being employed on the scene prior to the patient being loaded for transport. Once again, the family member may have started it, and then a compression device may have started. So we got to make that clear. No significant difference in ROSC survival from hospital admission or to hospital discharge. Was it noted? It wasn't clear. According to AHA guidelines and research, mechanical devices provided high-quality CPR and were favored for out-of-hospital cardiac arrest. There is currently ongoing needed research to evaluate the survival rate of patient discharge. They use this table here, which is from the ICOR, of level of evidence, which you guys, we all are familiar with that. Level of evidence value. One was a level of evidence 1. They found 4 articles that had a level of evidence of 2. They had 3 articles, level of evidence of 3. 0 had level evidence of 4, and 2 had level evidence of 5. So as you can see, it was sort of weighing back and forth. Credibility and clinical significance. It did provide credibility and clinical significance because, as we discussed, we're using these devices already, and there is evidence-based practices, but needs further evidence-based protocol. And that was their findings. Also, other barriers that they found were CPR and OHCA en route to the ED consist of lack of manpower for the EMS, small area to provide CPR in the ambulance, cannot defibrillate when performing manual CPR. So, as you can see, back and forth, there were things that were good and things that were bad. Recommendations. There's sufficient evidence from human RCTs to conclude that medical chest compressions during CPR for cardiac arrest are associated with benefit or harm. Are they good or are they bad? Widespread use of mechanical devices for chest compressions during cardiac is not supported by the review because they feel more RCTs that measure and account for CPR process are needed to clarify the potential benefit from this intervention. And I'll tell you why. From appraising this article, in conclusion, there lacks insufficient evidence to support or discount the use of mechanical CPR devices for out-of-hospital. There's some low-quality evidence suggesting that mechanical CPR can improve consistency and reduce the interruptions in chest compressions. There's no evidence that it helped improve survival. Future of the PICOT question. What could I do with this? We could further provide evidence-based research to go to our evidence-based practices, which are already going. Provide hands-on training to ED and ICU staff who may need to utilize these things. If you're that person in that small ER, or you're in the ER and your staff is becoming fatigued and they ask you to go get this compression device and you don't know how to use it, that may be scary for you. Provide the EMA, Emergency Medical Association, propose to them with EMS and hospital develop multidisciplinary teams to study ROSC and patient survival for their local areas. This would be huge. There could be grants that can come from this. There could be patient survival that can come from this. And also to develop subclasses and classes and subclasses. You got to evaluate multivariables. What was the age? What was the gender? What was the method of CPR prior to arrival? Was it witness? Was it non-witness? There's so many ways you can go with this. Future of the PICOT question. We need to be, and as a hospital, I can do this as well to participate in the team to report findings to databases and agencies such as AHA and Resuscitation Outcomes Consortium, Cardiac Arrest Epistry. Request representatives from these compression device companies to provide evidence-based practices with safety values, not research. Don't forget to include community involvement. Because as you know as well as I do, if you don't teach that patient about these devices and have brochures of why they're being used, there can be confusion. A little humor here. I'm a close relative and I did some research on the internet about his condition. So I feel I'm more qualified. See how you can be misled with evidence-based practice, protocols, and research. Thank you very much for your time.